Pratibha, you can start.
Okay, okay.
I think she got disconnected.
I'm sorry. I'm starting.
Pratibha, you can hear me?
Yes, ma'am, I can hear you, ma'am.
Yeah, start.
Okay.
Bye.
Good morning, everyone. Today I'm going to present on, I'm Dr. Pratibha, an anesthesiologist from Gayatri Medical College, and I'm postgraduate. Today I'm going to present on topic anesthetic concerns for non-obstetric surgeries in obstetric patients. Coming to the objectives, those include the introduction, incidence, etiology, and physiological changes in pregnancy, and anesthetic implications, and effects of anesthetic agents on mother and the fetus, and anesthetic plan. Non-obstetric surgeries during the pregnancies presents with a newer challenge to the anesthetist. The anesthetist lies, that is the mother and the fetus. For pregnancy, we have to understanding the altered pharmacology and understanding physiology is important. and proper counseling of the parturient is coming to the incidence. About 0.75% to 2% of pregnant women will require non-obstetric surgeries. In the first trimester, 23% of pregnant patients require surgeries. In the second trimester, 35%. In the third trimester, about 42%. Most common medical conditions which are rare, which are involved in non-obstetric surgeries in pregnancy are like sickle cell disease, diabetic ketoacidosis, and renal diseases like glomerulonephritis, pyelonephritis, and pulmonary diseases, and like pleural with basal pneumonia, and pancreatitis, and myocardial infarction, pericarditis, and drug addiction. And other surgical conditions like gynecological problems, most commonly the cervical encerclage, and others like ovarian cyst tumors, ovarian torsion, rupture, hemorrhage, and tubules, and tubo-ovarian mass, and uterine myomas, like a degeneration due to degeneration, and also infected uterine myomas and torsion. And pregnancy-related conditions, others like most commonly like cervical encerclage, and some other exit procedures. In non-gynecological problems, like most commonly appendicitis and acute cholecystitis, which is seen in 1 in 1600 individuals, and others like acute pancreatitis, and others like intestinal obstructions, trauma, visceral infections, and vascular accidents, like abdominal aneurysm, others like breast tumors. Coming to the anesthetic considerations, in the mother, there will be several physiological changes, and due to the physiological changes, the anesthetic, and in the fetus, we have to look for the teratogenic effects, and chances mostly about 5 to 10%, and chances of preterm deliveries, and we have to take care of fetal asphyxia. Coming to the physiological changes, implications. System-wise physiological changes, like coming to the cardiovascular system. In the cardiovascular system, the physiological changes like there will be 50% increase in cardiac output, and 10% increase in uterine perfusion, and decreased systemic vascular resistance, and decreased peripheral vascular resistance. And due to this, there will be uterine perfusion is as uterine related, and the hypotension is most common due to decreased systemic vascular resistance and decreased peripheral vascular. And which is hypotension is most common in regional anesthesia, and compared to that of general anesthesia, and it should be managed with left lateral tilt with a right side wedge place. And respiratory problems, like in the respiratory system, there will be ventilation and decreased end residual volume, and expiratory reserve volume, and decreased residual volume and functional residual, and increase in minute ventilation perfusion mismatch. Due to increase in minute ventilation and decreased in expiratory reserve volume and residual volume and functional residual capacity, faster use of inhalation anesthetics will be present, and due to increase in oxygen consumption and upward displacement of diaphragm and increase in the thoracic diameter, there will be hypoxemia varying in the positions, like in supine position and Trendelenburg position, and mucosal edema due to vascular engorgement. This leads to the difficulty in laryngoscopy. And in the central nervous system, there will be increased epidural venous engorgement. This due epidural venous engorgement, there will be decrease in epidural and increased sensitivity to the local anesthetics and opioids and sedatives. So more extensive local anesthetic spread. So decreased volume of local anesthetic should be used. Coming to the hematological system, there will be increase in red cell volume about 30%, increase in total leukocyte counts, which is normal, and increase in plasma volume by 50%, and increase in coagulation factors. There will be dilutional anemia and thromboembolic complications, like deep vein thrombosis, and dilutional anemia. There will be increase in red cell volume, but increase plasma volume is more drastic to that of the red cell volume. So this leads to the dilutional anemia. And decreased albumin and colloid osmotic oncotic pressure. Due to this, there will be edema and decreased protein. And in the gastrointestinal tract, there will be increased gastric pressure and barrier pressure. The increased aspiration risk. So aspiration prophylaxis should be given, and rapid sequence induction should be started immediately with cricoid pressure and succinyl choline, and followed by other drugs. And in the renal system, increase in the renal plasma flow and glomerular filtration rate. And due to this, there will be normal urea and creatinine levels. And if there are any deranged renal function tests asked during this condition, and decreased reabsorptive capacity, those leads to the glycosuria and proteinuria. Coming to the teratogenicity, teratogenic drugs cause direct effect on the fetus by changing the further secondary to prenatal treatment. This depends upon the dose, duration, gestational age dependent. The proven teratogens are like thalidomide. This leads to the absence of limbs. Like retinoic acid. This leads to the birth defects, and anticonvulsants. This causes neural tube defects, and folate antagonists like also causes neural tube defects, and also radiation. And benzodiazepines, if they are used for prolonged during the surgery, this may cause there may be some effect. Most commonly cleft lip and cleft palate, which was seen in the animal studies, like most commonly which is seen is with diazepam. And coming to the uteroplacental transfer of drugs, the drugs placental transfer are atropine, benzodiazepines like diazepam and midazolam, and intravenous induction agents like propofol, thiopentone, ketamine, and etomidate, and local anesthetics, all local anesthetics, chloroprocaine. And opioids like morphine has more uteroplacental transfer when compared to the alpha-2 agonists like clonidine and dexmedetomidine, and antihypertensive drugs like beta blockers and nitroglycerin and ephedrine that cross the glycopyrrolate, heparin, depolarizing and non-depolarizing muscle relaxants, phenylephrine, neostigmine, insulin, and volatile anesthetics. Coming to the effect of drugs on fetus, there is no convincing evidence about the teratogenicity. There is a weak link between nitrous oxide and DNA synthesis. Inhalation agents in the early pregnancy and GABA aminobutyric acid agonists and NMDA antagonists like barbiturates and accelerates the apoptosis, and this have effect on unborn, and there may be delayed learning phenomenon, and further vulnerable to synaptogenesis, which can be seen from 3rd trimester to 3 to 4 years of age. Coming to it is in animal studies, it is a weak teratogen in rodents. It interferes with the function of methionine synthase by oxidation of vitamin B12, and it decreases the tetrahydrofolate synthesis, which is required for the DNA synthesis. Due to decrease in tetrahydrofolate, there will be decreased DNA synthesis in developing fetus. And drugs, some of the drugs and the side effects and anesthetic implications. Coming to the inhalation agents like volatile anesthetics. In volatile anesthetics, side patients are due to volatile anesthetics, there will be decrease in minimum alveolar concentration and decreased uterine tone and hypotension. And nitrous oxide, it on prolonged pressure may inhibit the DNA, so avoided in the first trimester. And neuromuscular blocking drugs like succinyl choline, the reduced plasma cholinesterase, there will be possibility of prolonged action. And non-depolarizing drugs like they are quaternary ammonium compounds, so they do not cross the placenta. And local anesthetics, uh, and they reduce the protein binding and increase the risk of toxicity. So use of low intrathecal doses in pregnancy. And opioids, they have increased maternal sensitivity and fetal withdrawal, and there will be chances of intrauterine growth retardation on chronic use. In coming to the anticoagulants like warfarin and heparin. Warfarin as a teratogenous as it crosses the heparin, and it does not cross the placenta. Do not cross the placenta. And anticholinergics like atropine and glycopyrrolate. Atropine causes fetal tachycardia, and and glycopyrrolate, as it is a quaternary ammonium compound, it do not cross the placenta, so it can be used. And anticonvulsants like phenytoin, carbamazepine, sodium valproate, and magnesium sulfate. Phenytoin and carbamazepine, they causes congenital malformations like neural tube defects and the seizures. And magnesium sulfate, it has a magnesium sulfate causes muscle weakness and interaction with neuromuscular blocking agents. And antihypertensives like AC inhibitors, growth retardation, oligohydramnios, and renal impairment. And beta blockers also causes intrauterine growth retardation and neonatal hypoglycemia and bradycardia. And diuretics like thiazide diuretics, they causes cytopenia. And tocolytics like beta 2 agonists like ritodrine, terbutaline, and salbutamol, they prevents the premature labor. The side effects like tachyarrhythmias, pulmonary edema, hypokalemia, hyperglycemia, and oxytocin receptor antagonists like atosiban. They got side effects like nausea and vomiting. And calcium channel blockers, the anesthetic implications like it causes a hypotension. Coming to the fetal risk categories, category A, B, C, D, and category X drugs are there. In category A, there is no risk to the fetus during the first trimester as well. In category B, animal studies demonstrated no fetal risk, but no control studies have been performed in humans. Category C, fetal risks in animal studies which are teratogenic and embryocidal, but no studies in humans. Category D, human fetal risk, but benefits are acceptable despite. In category X drugs are contraindicated in pregnancy, and there is an evidence of teratogenicity in fetal risk in animals and human studies. And most of the anesthetic drugs belongs to category B and C, and some of the drugs which belong to category B like methotrexate, propofol, enflurane, and isoflurane, desflurane, sevoflurane, lidocaine, ropivacaine, and fentanyl. Coming to the algorithm for non-obstetric surgeries during the pregnancy, which is decided between the anesthetist and obstetrician. When a pregnant patient comes to the surgeries, non-obstetric surgeries, they can be divided into elective surgeries, essential surgeries, and emergency surgeries. Surgeries can be delayed until postpartum, and in surgeries, if it is an essential surgery which required immediate surgery within few hours, if it is in the first trimester, if there is no or minimal risk, if there is a risk, there is increased risk to the mother, we can proceed with the surgery. If there is a minimal risk to the mother, the delay they can be delayed until for emergency surgeries which required immediate intervention within few minutes, they should be proceeded within few minutes by optimizing, if required, for the mother, and modified anesthetic considerations for maternal and physiological changes and fetal well-being, and consultation with the perinatologist or by consulting with the perinatologist and obstetrician. And intraoperative and post-operative fetal and uterine monitoring may be useful. In timing, coming to the timing, postpone the elective surgery until delivery, and second trimester for organogenesis, and as organogenesis is completed at the time, and emergency surgery should be professional age, and open versus laparoscopic surgeries. Laparoscopy safe, and as it is as there will be a loss, and post-operative recovery is recovery will be early mobilization, and patient can be easily mobilize, then will be decreased chances of thromboembolism and DVTs. Coming to the prophylaxis, corticosteroid administration for fetal and maternal benefit after 24 weeks, and thromboprophylaxis for venous thromboembolisms. Corticosteroid prophylaxis like betamethasone and dexamethasone can be given. Betamethasone about 6 milligrams can be given for 24 hours in 2 doses, and dexamethasone is given in 4 doses in as a 4 milligrams in 4 doses as apart. Coming to fetal considerations in the first trimester, in first 12 weeks, fetal organogenesis starts. So avoid hypothyroidism, hyperthyroidism, hypoxemia, and hypercarbia. In the second trimester, is the preferred for non-obstetric surgeries. Lowest risk of preterm delivery. Sorry. Field for surgical exposure, as the uterus is in the lower segment, and major embryonic development is completed by 8th week. In the third trimester, all concerns related to first and second trimester also apply in the third trimester as long as labor has not begun. Administering corticosteroids facilitates the lung maturity. After discussing with the consultant obstetrician, NSIs are avoided after 32 because of premature patent ductus arteriosus closure, and elective surgeries like should be planned mostly in the second trimester, and essential surgery should be planned in the second trimester as there is a risk of teratogenicity is less. Meticulous anesthetic techniques to maintain the hemodynamic stability like uteroplacental perfusion as there is regulation. Coming to the maternal anesthetic concerns in the first trimester, after 6 to 8 weeks of gestation, hemodynamic, respiratory, and metabolic and pharmacological parameters are altered. So in maternal, adequate oxygen requirement and modified drug pharmacokinetics and careful airway manipulations. And fetal risk, like there may be chance of risk of teratogenicity and impaired uteroplacental blood flow. Anesthetic concerns in the maternal concerns are aorta caval compression after 20 weeks, which should be taken care by left uterine displacement or right side wedge placement. And there may be chances of they may prone to uterine asphyxia due to vasoconstriction, and there may be aspiration prophylaxis should be started with the H2 receptor antagonist, and non-particulate metoclopramide and non-particulate sodium citrate can also be used, and preparation of difficult airway cart and avoiding hyperventilation because there may be chances of uterine vasoconstriction and uterine decreased blood flow to the uterus, and hypoxia to the uterine hypoxia, fetal can be present, and there may be increased chances of thromboembolic complications. In the fetus, there will be preterm labor, growth retardation, and intrauterine hypoxia, second and third trimester. Coming to the preoperative preparation, in preoperative visit, careful history and examination should be taken, and adequate required investigations. Plan of anesthesia, whether it is general anesthesia or regional anesthesia, reassure the patient, and all the techniques, all the methods we are going to do to the patients, and antacid prophylaxis, and transport the patient in a left lateral position due to the supine hypotension, aortocaval compression syndrome. And the anxiolytic premedication to allay the anxiety and apprehension, and DVT prophylaxis, most commonly like used with low molecular weight heparins, and benefit. And role of tocolytics is controversial. And OT preparation with drugs and suction should be ready. Anesthetic. Coming to the anesthetic management, choice of anesthesia depends on patient's present surgical status, site and nature of surgery, and gestational age of the fetus, physiological changes, and other coexisting diseases. No technique has been proven to have superiority and other superiority over the other, and regional techniques may be preferred. Safe anesthetic management is also very important. Coming to the monitoring, maternal monitoring like non-invasive blood pressure and invasive blood pressure monitoring, cardiography, pulse oximetry, capnography, blood glucose levels, temperature monitoring, and external Doppler device for fetal heart rate monitoring, tocodynamometer for fetal uterine contractility. Fetal monitoring during the surgeries like fetal heart rate monitoring by using transabdominal Doppler ultrasonography, beginning at 18 weeks to 20 weeks of gestation, and transabdominal Doppler monitoring is not possible in abdominal surgeries or in obese patients. So sonography is according to the American College of Gynecologists, fetal monitoring is individualized and based on gestational age and type of surgery and facilities available. Monitoring of uterine contractions, dynamometer is placed outside the surgical field. Contractions are monitored intraoperatively. If uterine contractions are detected, maternal hemodynamics can be improved. More IV fluids and tocolytic treatment is required. Coming to the goals of general anesthesia, like secure the airway, as there are chances of risk of difficult airway and aspiration due to mucosal edema and airway edema during the pregnancy, and maintain normoxia and fetal effects because of a decreased hypercarbia. This leads to the fetal effects like fetal acidosis. Because of decreased functional residual capacity, reoxygenation for about 3 to 5 minutes is appropriate for ventilator adequate oxygenation and ventilation, and maintain adequate uterine blood flow for uteroplacental circulation, charting, and avoid itocaval compression by left lateral tilt, and rapid sequence induction by using thiopentone sodium or succinyl choline, and cricoid and tracheal intubation with a smaller size tubes. And coming to the maintenance is with muscle relaxants and opioids with lower doses, and inhalation agents with MAC less than 2 MAC with high concentration of oxygen is recommended. Adequate analgesia to reduce the stress, and multimodal use at multimodal analgesia by using NSAIDs, and extubation. Extubation should be smooth extubation, and close monitoring intraoperatively, and in recovery for fetal monitoring. Ketamine increases the uterine tone and fetal asphyxia, so should not be used. Positive pressure ventilation may reduce the uterine blood flow. Magnesium for tocolysis, reduce the dose of neuromuscular blocking drugs, as magnesium sulfate prolongs the action of neuromuscular blocking drugs. And role of tocolytic therapy in pregnancy is for routine administration of prophylactic perioperative tocolytic therapy. It is indicated in selected cases with irritable uterine activity, and other tocolysis like indomethacin. It reduces the risk of delivery 48 hours of initiation of treatment. It inhibits the prostaglandin synthesis essential for labor process, and maternal side effects. It causes maternal side effects like platelet dysfunction, effects like premature closure of patent ductus arteriosus, bronchopulmonary dysplasias, and intraventricular hemorrhage. And calcium channel blockers like they reduce the inflow of, and other tocolytics like calcium channel blockers, they reduce the inflow of calcium in the cell, thereby inhibiting the calcium channels and decrease the myometrial contraction and causes the uterine relaxation. And maternal side effects like tachycardia, There will be maternal side effects like tachycardia and hypotension, and other tocolitis like beta 2 agonists, example ritodin and terbitalin. The mechanism of action is the cyclic AMP levels and decreases the uterine contractions and causes the relaxation, prevents the premature labor, and side effects due to the beta 2 agonists like tachyphylaxis and tachycardia, hypotension, arrhythmias, and pulmonary edemas. Pulmonary edema, fetal tachycardia, hypoglycemias. And less effective drugs like other tocolytics like oxytocin, example atosiban, and magnesium sulfate, and progesterone supplementation. Coming to the regional anesthesia, the advantages over general anesthesia is minimal fetal drug exposure when compared to general anesthesia, avoidance of complications due to general anesthesia, and post-operative post-op analgesia, reduced local anesthetic requirement, and decreased local anesthetic toxicity. And so during regional anesthesia, hypotension by adequate preloading and maintaining the left uterine displacement. In patients of MJSO4 are more prone for hypotension, and often so they are required treatment with. And some of the special conditions like laparoscopy, risk associated with during laparoscopy are uterine or fetal trauma and fetal acidosis due to if there is an increased carbon dioxide insufflation, maternal cardiac output, and uterine perfusion. Monitor the end-tidal carbon dioxide levels to avoid maternal hypercarbia, about normally about 30 to 34 mm of Hg, and use low pressure pneumoperitoneum, about 10 centimeters of water to 12 centimeters of water, and limit the extent of positions like Trendelenburg position, reverse Trendelenburg position, and try to maintain the uterine displacement. In cardiac surgery, changes during the symptoms of pre-existing heart diseases. Stenotic pathologies like in stenotic pathologies during percutaneous balloon valvuloplasties are commonly done during pregnancies. And in cardiopulmonary bypass surgeries, there is increased risk to the fetal, non-pulsatile perfusion, low perfusion pressures, and emboli to uteroplacental and maternal release of catecholamines. And in a bypass surgery, if bypass is required, cardiopulmonary bypass is required, maintain uteroplacental blood flow and high pump volumes of more than 2.5 liters per minute, and the perfusion pressure should be more than 70 mm of Hg. And maintain adequate hematocrit levels of more than, and maintain normothermia, hypocapnia for adequate if there is an hypocapnia, uteroplacental vasoconstriction will be present. There will be decreased oxygen delivery and fetal distress will be present. And if there is a hypercapnia, there will be fetal acidosis. In complications during the surgeries, like during cardiac surgeries, are like pulmonary edema, arrhythmias, myocardial infarction, stroke, heart failure, and finally the leads to death. Coming to the during neurosurgery, intracranial hemorrhage is secondary to aneurysmal rupture or arteriovenous can be neurosurgery emergency, and treatment includes controlled hypotension, hyperventilation, and osmotic diuresis. Osmotic diuresis like mannitol. And in pregnancy, particular care is taken as reduction of mean arterial pressure below 70 mm of Hg reduces the perfusion, because during the pregnancy fall in the mean arterial pressure due to decrease in systemic vascular resistance and decreased systemic vascular resistance. Therefore, fetal monitoring is necessary. Extreme hyper uterine artery vasoconstriction, and reduce the uterine perfusion. And the hyperventilation shifts due to hyperventilation shifts the maternal oxygen hemoglobin dissociation curve to the left, leading to decreased oxygen supply to the fetus, leading to fetal hypoxia. And osmotic diuresis, diuretics used to reduce the brain edema, can decrease the amniotic fluid volume and causes negative fluid shifts from mother to the fetus. And mannitol and thiazide should be Mannitol and thiazide should be cautiously used. In trauma patients during the pregnancy, primary and secondary survey should be directed towards maternal well-being. Important in trauma evaluation, during the first trimester, fetus is protected by the bony pelvis, less trauma to the fetus. As the pregnancy progresses, uterus is not only exposed but also causes pressure on the inferior vena cava and aorta and potentially compromising the perfusion and resuscitation. Carries a risk to the carries a risk in causing the intrauterine death, fetal injury, and abruption of placenta. And coming to the post-operative pain control, maternal pain control decreases the risk of preterm labor. Prophylactic tocolytics can be given, and multimodal analgesia is recommended. And epidural analgesia, like multimodal analgesias, like epidural analgesias, with and after the delivery of the fetus. Before the delivery of the fetus, if opioids are given, it crosses the placenta and reduces the fetal heart rate variability. And NSAIDs are avoided as there is a risk of miscarriage and fetal malformations when used in early pregnancy. Premature closure of patent ductus arteriosus and oligohydramnios when used after 30 weeks of gestation. And acetaminophen can be, or paracetamol can be used as it is safe. Coming to fetal considerations, minimally invasive fetal procedures like minimally invasive procedures like ultrasonography and can be done under sedation. And during fetal procedures, like indications of exit procedures like ex utero, intra, in congenital diaphragmatic diaphragmatic hernias, lung hypoplasias, and cystic hygromas, hydronephrosis, and meningomyelocele should be done mostly in the second trimester because at the time the embryogenesis will be completed. And cystic hygromas, like cystic hygromas, hydronephrosis, and meningomyelocele, and mid-gestations like risk of preterm and chorioamnionitis. And main goal is to maintain the fetal and maternal homeostasis. Coming to the risk summary, risk profile must be assessed for the fetus and the mother. Postpone the if it is an elective surgery or essential surgery, as it is the safest period, and optimize the mother and the fetus and maintain uterine blood flow and avoid hypercarbia, stress response, and myometrial stimulation to prevent premature labor, and fetal heart rate monitoring preoperatively, intraoperatively, and postoperatively, and use the regional anesthesia as appropriate for surgery. Thank you, everyone. My references are from Miller's 9th edition, Chestnut's Obstetric Anesthesia, and Tata Memory.
Thank you, Pratibha. Very good presentation. And it is very important in non-obstetric management, anesthetic management in non-obstetric surgeries, because we have to, anesthetic management includes taking care of two clients in one situation, including the disease process itself. And another thing is, whenever general anesthesia is required, pain management is also very important because lighter planes of anesthesia can cause sympathetic stimulation, which in itself can cause disturb the uteroplacental blood flow. And these are the important things. Very good presentation, Pratibha. Any questions from anybody? Shekhar, Shrikant.
Madam, that's an extensive class. Everything is explained. I just want to ask one question to the student. What is your first choice of tocolytic in a case of uterine inversion?
First choice, if it is
Pratibha?
sir, ma'am.
Tell.
Sir, I prefer Ritodrin, sir. Ritodrin and
Actually, you said that. Actually, you mentioned in your PPT also.
yes,
It's
sir.
nitroglycerin.
Nitro.
Yes,
It
it's
causes uterine
nitroglycerin.
relax.
Yes. If there is an
Yes, sir.
uterine inversion, you can give just nitroglycerin and keep just sedate the patient with some IV anesthetic,
Sir.
which is not in line with nitroglycerin. That means it should not cause hypotension also. Like ketamine you can use, and you can just put the uterus in place, retrovert it again. Okay,
Yes, sir.
thank you.
Yes, sir. Thank you, sir.
Anybody else? Anuradha?
Good morning to all.
Good morning.
Pratibha, you did
Chandana?
very well. Each slide is important.
Yes, ma'am.
And lastly, you told about the fetal considerations.
Yes, ma'am.
So always you have to avoid the hypothermia, hyperthermia, hypoxemia, hypercapnia, hypotension.
Yes, ma'am.
And best period in second trimester for non-elective surgery. Why is it is best in second trimester?
Because at that time, till that time, organogenesis will be completed, ma'am.
Okay. So by the time embryonic development
Embryonic
is complete,
development.
8th week.
Yes,
So
ma'am.
that's why low risk of surgeries if you do in second trimester.
Okay.
And you told about the steroids, NSAID is avoid, NSAID avoid because premature
Premature closure of
PDA
fetal
closure.
development. Yes, ma'am.
Next, fetal monitoring also very important.
Yes, ma'am.
And monitoring of uterine contractions. So tocodynometer and uterine contractions monitoring intraoperatively, that is also important. Main thing lastly is post-operative analgesia is very important.
Okay.
And go for regional. You told about try to go in regional anesthesia.
Anesthesia.
And cardiac surgery wise, you told about the
Velu-
is it chances of fetal hypoxia
hypoxia.
because it is a non-pulsatile flow, no, that
Yes,
time.
ma'am. Yes,
So
ma'am.
that's why inadequate perfusion pressure, inadequate pump flow, embolic phenomena. So everything will develop.
Yes, ma'am.
So laparoscopic surgery also you told.
Yes, ma'am.
Okay, everything you told.
Yes, ma'am.
So very nice presentation. Thank you.
Thank you.
Thanks, Anuradha.
What is the most important test to diagnostic in pregnancy?
Sir, thromboelastography we can do, sir.
No.
Final test is like thromboelastography, sir.
Dick in pregnancy.
In pregnancy.
What is DIC?
Disseminated intravascular.
Estimation of D-dimers.
D-dimer levels, sir.
What is the normal level?
Point. Then
If it is more than 2000 nanograms, it is diagnosed. What is the best antihypertensive drug in pregnancy?
labetalol can be given, sir, during the pregnancy.
Dose?
It's about 50 milligrams, sir.
No. It available as a 100 milligrams tablet, no? What is the side effect of labetalol?
Labetalol, there will be should be avoided in congestive and
It induces bronchospasm, so it should be used carefully in lung sensitive. If patient throws a fit in pregnancy and patient is on magnesium sulfate, what will you do?
Sir, will pre-oxygenate the patient, sir, if required, if there is a requirement of oxygen.
You should estimate the urine output and creatinine levels and magnesium levels. And what is the best antidote for magnesium toxicity?
Sir?
Best antidote for magnesium toxicity.
Magnesium toxicity antidote is.
Pratibha, the question is patient is on magnesium sulfate. Huh? Where you will give? The magnesium sulfate is given.
Ma'am, I can't hear properly.
Now you can hear me?
Yes, ma'am, now I can hear you.
So the patient is on magnesium sulfate for PIH patients. Or eclampsia. Now toxicity happened, then what you will do?
Before treatment, how do you know this patient developed magnesium toxicity?
Before treatment means there will be seizures, no? Then hypotension will be present, ma'am, and
which parameters have to see?
You have to check the knee jerks.
And knee jerks, reflexes and knee jerks we have to check, ma'am.
What about urine output?
Urine output also. Magnesium levels will check for the urine output, ma'am. Renal function test we will check, ma'am.
Any changes in ECG? And I forgot it. That's why I'm asking. What is the antidote of magnesium? Sir, asking about that question.
Calcium, madam.
Calcium gluconate, ma'am.
Which is superior in calcium gluconate or calcium chloride?
Calcium chloride, sir.
Calcium chloride.
Then why you have to tell calcium gluconate? You should tell calcium chloride if available.
Which drug you are using in your institute? Gluconate or chloride?
Gluconate, ma'am. Calcium gluconate, ma'am.
Any difference between the gluconate and chloride?
Calcium chloride has more ionic calcium compared to calcium.
Good.
More ionic calcium.
The exam will ask about the calcium chloride and gluconate and magnesium toxicity. And I think ECG changes also will occur, and urine output and knee jerk.
Okay.
How do you differentiate eclampsia from pregnancy-induced hypertension?
After 20 weeks of gestation, pregnancy-induced hypertension in this month.
Yes, good, good. Thank you.
Thank you, sir.
Very nice class.
So always remember the eclampsia, preeclampsia, and pH definitions also.
Okay.
What is HELP syndrome?
Ma'am?
Question can be answered by any student in the who is listening to it. It's not only for the speaker. Anybody can answer.
Ma'am, what was the question, ma'am?
After eclampsia, preeclampsia, eclampsia, what type of syndrome is developed?
It's HELP syndrome.
Helps.
Abbreviation of HELP.
Hemolysis, elevated liver enzymes, and decreased platelet count, ma'am.
How do you know this patient developed HELP syndrome? Any parameters?
Thrombocytopenia, and
Anuradha,
Oh, yeah, please.
next class prepare. This
Yeah. Thank you.
She will prepare for the next class.
Thank you, Manjula.
Thank you.
sir.
Thank you.
Sir,
This was a nice class. Thank you very much.
Well
Thank
done,
you,
Pratibha.
everybody.
Thank you so much, Manjula.
thank you.
Thank you to all.
Yeah, thank you very much.
Thank you. Thank you so much, ma'am, for giving me this opportunity.
Shall we disconnect? Very good, nice presentation. But whenever you are presenting, you have to write your name and